Alrighty, well, why don't we go ahead and get started? My name is Nicholas Franco, and I'm a research coordinator here at the University of Washington. And it's my pleasure to welcome everyone to another session of the ACP Long COVID Interest Group. Today we have a fantastic presentation, and I will let Dr. Anita Chopra introduce our guest and get the conversation going. Over to you, Dr. Chopra.
Thank you, Nick. I'm really excited for today's session because not only is the topic very challenging, but also our guests today are, that's their niche area. So I'm really excited to learn from them. Hello, everyone. I'm Anita Chopra. I am one of the lead physicians at the University of Washington Long COVID Clinic, and I chair this Long COVID interest group through the ACP. And I am very, very excited, and it's an honor to have our expert guests today to talk about the neurological complications of long COVID. Dr. Andrew Schamess is an associate professor in general internal medicine at the Ohio State University. He's one of the lead physicians in the post-COVID recovery clinic, which has been operating since 2021. He is the principal investigator of a pilot trial of amantadine for treatment of cognitive symptoms in patients with long COVID. He hosts the Long COVID Clinical Podcast with myself, Dr. Tiffany Walker, and Dr. Aaron Friedberg. He's one of the founding members and a co-director for the American Academy of infection-associated chronic conditions. In addition to long COVID, he runs a primary care clinic for adults with sickle cell disease and is working on a mobile application for mindfulness-based pain management for patients with sickle cell. Thank you, Dr. Schamess, for coming today. It is an honor to have you here.
It is such a pleasure and an honor to be here. And I love collaborating with Anita on anything. So this is great.
Thank you. I'm also excited to welcome Hiba Amar. Hiba is an MD. Before applying for medical residency, she wanted to learn more about research, and she has been working at the Ohio State University for over a year now and works on conducting experiments on long COVID, especially mouse experiments on long COVID. And I'm very excited to find out about her research, which is so very relevant to the cognitive symptoms of long COVID. So excited to have you both. And I'm going to start off by asking you, questions about your research, Dr. Schamess, and again, Hiba as well. But before that, how did you start using amantadine specifically for long COVID at the Ohio State University?
So thanks for that question. And so when I started in the long COVID clinic, and I'm sure this experience will resonate with a lot of you here who've taken care of long COVID patients, we're in a situation with really a brand new disease and no clear evidence-based tools for treating it. So when the patient walks in the clinic, we do have an approach, and the first things we do are probably very similar to what you do. We listen, we provide validation, we provide patients with disease education, we recommend behavioral measures that might help them to get more rest and to pace themselves. We have a good cognitive rehabilitation team run by our speech therapists, and we have a physical therapy program that I'm really proud of. Some really smart physical therapists have been working with these patients. So we do all that stuff. And some patients, as I'm sure you know, really do great with that, and they come back and say they're much better. But the ones who come back for that second visit or third visit and they say, Doc, I still am in a fog all the time. I'm exhausted all the time. I can't do my work. I'm really scared about what's happening to my concentration and my intelligence. All right, so what do you do for those patients? So, and I think for all of us, we're looking at repurposed medications. We're drawing on what experience we have in other conditions. And maybe I can, Anita, is it okay if I share my screen? Okay, let me do that.
Absolutely, yes.
Okay, let's see. And okay, and let me put it in slide mode 1 sec. Wait a second. There we go. Okay. Are you guys seeing slides? Good. Okay. Yeah. So anyway, so we're going to show, these are some of the things we're going to talk about in this session. So for me, I had done a lot of work with traumatic brain injury patients. And so I had some tools for treating those patients. And those of us who have worked with TBI and long COVID, the similarities are really clear between the brain fog that patients with TBI get and brain fog in long COVID. And the deficits seem to really be overlapping: memory, attention, executive function, processing speed, often with an overlay of depression and anxiety. And so I looked at the medications in common use for TBI. All right, well, the amphetamines, which I just did not feel comfortable using in my long COVID patients, some of the other ones that I just wasn't as familiar with, like bromocriptine and levodopa, but amantadine. I had used amantadine. I was comfortable with it. I thought if it worked for the TBI patients, maybe it would work for my long COVID patients. So kind of a wing and a prayer, really. But when I had enough experiences where I would give a patient amantadine, and some of these patients would come back and say, "Holy cow, that was a game changer. Dr. Schamess, nothing else has helped me, and now I really am starting to feel like myself again." Now, one has to be suspicious of these anecdotal experiences, right? Because I mean, I think for almost any treatment or supplement, there's going to be some patient out there who says, "This was amazing, this cured me." There's a big placebo effect in long COVID. Um, when we'd done a small number, like 14 amantadine patients, we, as part of a larger study where we're tracking outcomes, quality of life outcomes in our patients, we just did kind of an informal look at patients who'd had amantadine versus those who hadn't. And this is looking at how many patients in the two groups had a 10% improvement in fatigue, sleep disturbance, anxiety, and depression. And the numbers looked better with amantadine, right? They looked better than in the non-amantadine group, which gave us at least some background data, not a controlled trial, not carefully collected, but some sense that maybe, there was some effect here. I'll also say, it's equally interesting to think about the patients who didn't respond, right? If some of them did, why did those people respond and why did others not? And is there some differentiating factor or some biomarker we could look for that might help us tell who is most likely to benefit from a particular drug, so it's not all complete trial and error? I'm sure you guys know what I'm talking about if you're taking care of these patients. This came out after we'd actually started our controlled trial. This was a study from Iran that came out in January of this year and got surprisingly little press because it was actually pretty well conducted. It was open label, but aside from it not being blinded, they did do they randomized patients to amantadine versus no amantadine. This was a 2-week trial, 33 subjects in each group, and they were looking at fatigue as an outcome. And they measured that on a visual analog scale and then this fatigue severity scale, which are both validated measures of fatigue. The dose was the same as what we've been using, which is 100 milligrams twice daily. So if you look at the before treatment differences between the amantadine and placebo groups, they're non-significant differences. In other words, they both had placebo and amantadine at baseline had basically the same level of fatigue. After treatment, there's a large statistically significant difference between the two groups in how many in the scores on these two scales. So that was nice to just see that confirmation that it's not just us, like other people are seeing this effect with amantadine. So let me stop there. Anita, do you have other questions before I go on?
Yes, I wanted to just, I loved what you said about, just sort of giving an overview of the brain fog as well, and your sort of just shooting an arrow in the dark. Amantadine worked for TBI patients, and you decided to use it here. But this is a very, very exciting trial that you are going to talk about soon. But just for the benefit of our primary care providers here who find, like me, will find brain fog as one of the most, first of all, abstract symptom, and second of all, most challenging, where patients have all these, this constellation of symptoms that are not really making sense. And do they have ADHD? Do they have depression? Is there an overlap? Can you, Andrew, talk a little bit about a little bit more about the symptoms that you hear from patients that they're experiencing just in the brain fog? And brain fog, as we know, is a lay term just for the state of fogginess in their minds and just the constant malaise. Can you talk a little bit about that?
Yeah, I will say, to me, and I mean, again, I'm assuming a lot of people on this in this meeting have seen these patients, so you probably don't need me to outline what brain fog feels like. But the things that I guess just offhand, I hear again and again from patients, first of all, that like they often point to the word finding difficulties. I had the one that sticks in my mind is a woman who is a wildlife biologist and runs a nonprofit. And she would go out with her team after she got COVID and had long COVID, and she could not find the word for hollow log. So she, after pausing and stumbling for a while, she said, "No, look in the empty trees," right? So, the like empty tree instead of hollow log. But people have word finding difficulties, and it's alarming to people who are usually articulate and quick on their feet. Um, they have trouble remembering what they're saying. Often they'll just lose their train of thought in the middle of a conversation. They have difficulty learning new information. So people who, for example, are in the sciences or in law or in academics just find that they're reading the same thing over and over and can't learn. Um, and more, but that's sort of the general picture of it. And I think it's very alarming to people who need to either, manage complex multitasking or learn new information or teach as part of their jobs. The other distinction I might just make that's interesting is if you take a population of people who've had SARS-CoV-2, regardless of whether they have post-COVID, like people who are completely recovered, and do cognitive testing on them, a lot of studies have shown that they perform below the norms, right? So there's kind of a suspicion that all of us, after we get SARS-CoV-2, may lose a few IQ points. And we don't know long term whether that comes back or it doesn't. But there's surprisingly little overlap between the measured cognitive defects on cognitive testing and brain fog, right? So a lot of patients who say they have brain fog and are really, really impaired by this test normal on cognitive testing. And a lot of people who don't have brain fog test abnormal. So I think brain fog is real. I think cognitive impairment is real. I'm not sure they're the same thing.
That's very fascinating what you said. And also what is very striking is the relationship or the overlap between fatigue and brain fog. And patients, when they are very tired, they have more cognitive symptoms. And if they are pushing themselves to a point of crash, the brain fog is more pronounced. So thank you very much for outlining that. And I really found it very interesting what you said in the end, that you're not sure if they are the same thing. So is there any theory of why amantadine helps patients, and what is the mechanism of action?
So I'm glad you asked because I have slides prepared on that. That was the two things that kind of came together for us in terms of doing this study. One was the data I just showed, preliminary data that showed there might be some benefit, but the other was stumbling upon a potential mechanism of action. And how that happened, some of you may remember this article that came out. It was Lisa McCorkle and Eric Topol and their collaborators in early 2023. And they wrote about what was the state of the art, what was known about the pathophysiology of long COVID. And so I went through it with a fine-tooth comb, like everybody else I knew. And the study that stood out to me, because it just seemed new, I mean, I just had never heard of the stuff they were talking about, was this one. Bruce Brew was the senior author, and Sisik was the first author. And so what they did, they it was about what's called the kynurenine pathway, which I will explain in due time. But they took 128 subjects who'd had SARS-CoV-2. About half of them, or not quite half, didn't have any prolonged symptoms. They had fully recovered. And the other half had persistent symptoms, post-COVID syndrome. And that was about half and half, kind of mild post-COVID syndrome versus disabling post-COVID syndrome. They followed them for 12 months with neurocognitive assessments. So they did cognitive testing, and they also did patient-reported measures of brain fog and functioning. And they measured these kynurenine metabolites, which at the time I read this study, I'd never heard of. And then they had other control groups for their lab measures. And then they looked at the prevalence of objective cognitive deficits, which was about 15 to 25%, because they did the tests at different points in the year. So the prevalence was different at different time points, but over the course of 12 months. And as we mentioned before, there was relatively low correlation between the brain fog symptoms and the cognitive deficits. But what they found was that this kynurenine pathway was active and correlated very strongly with the cognitive deficits. So the one marker of the kynurenine pathway that really seemed to best predict cognitive deficits was quinolinic acid, right? And so high quinolinic acid levels were seen much more frequently in patients with cognitive impairment than those without. And in their sort of laboratory control group of people who were healthy and had not had SARS-CoV, there was zero abnormality. So quinolinic acid, okay, interesting, seems to be a biomarker of cognitive impairment. What exactly is quinolinic acid? So interestingly, it's part of the tryptophan metabolism pathway, right? And tryptophan has come up a number of times in high-profile articles. I think the when it really came to everybody's attention was last year, this article in Cell, where they found that there were lower tryptophan levels in patients with PASC, and that was due to the immune system or the virus shutting down absorption of tryptophan from the gut through enterochromaffin cells. Now, what does tryptophan do? Well, by one metabolic pathway, it's metabolized into serotonin and melatonin. And so in this earlier Cell study, they found that serotonin levels and melatonin levels were low in patients with PASC. Tryptophan, as an essential amino acid, obviously is used in protein synthesis. And then the other thing that happens is it's metabolized by what's called the kynurenine pathway. And this happens in two different situations. First of all, in the liver, where it's metabolized by TDO. And that's really just kind of regulating tryptophan levels in the blood. So that enzyme is responsive to tryptophan levels. The higher tryptophan is, the more it metabolizes. That's in the liver. In the rest of the body, like the brain and immune cells and many other tissues, it's metabolized by the IDO pathway, and that is not responsive to tryptophan levels. It's responsive to immune signals, right? So interferon gamma and TNF alpha all stimulate the peripheral kynurenine pathway metabolism of tryptophan. And what are the products? Well, kynurenic acid, which is really interesting immunomodulator, which I'm not going to talk about, and some other stuff I'm not going to talk about, but it produces quinolinic acid. Quinolinic acid is really on the way to producing NAD+. You may remember, if you guys remember being tortured by the Krebs cycle in biochemistry, right? NAD+, this is the de novo pathway for synthesis of NAD+, which is the electron acceptor in the Krebs cycle, right? So it's essential for mitochondrial function, which is another interesting kind of thing that borders on the tryptophan pathway, because there's also a lot of interesting work on mitochondrial dysfunction in long COVID. But this kind of intermediate product, quinolinic acid, is the one that we're interested in right now. Okay, and just on the kynurenine pathway, it's not just PASC. Like there's all these neuropsychiatric conditions where the kynurenine pathway seems to be overactive and produce too much quinolinic acid. Okay, so how does this relate to the brain of people with PASC? This is just one slide, and there have been lots of other studies that showed the same thing in different ways. But if you look at autopsy findings of patients who died with COVID-19, the kind of dark brown staining is microglia. So these are, in 80% of patients, moderate to severe microglial inflammation was seen. Other things that you would expect in somebody who might have died in the ICU, but this microglial inflammation is really somewhat unique to long COVID. And in fact, if you talk to pathologists, they'll say you could tell them nothing about the patient. If they see this pattern, it's going to be somebody with COVID-19. So there's inflammation in the brain. Okay, I don't know about you guys, but I had to remind myself, what is a microglia exactly? What are these different supporting brain cells? So there's three main ones: oligodendrocytes, which make the myelin; astrocytes, which conduct all sorts of constitutive and cleanup work in the brain and plug holes in the blood-brain barrier and do all kinds of interesting, helpful things; and microglia, which are the immune cells of the brain. So these are like sort of like the macrophages of the brain. All right, so I mentioned that outside the liver, tryptophan is metabolized in peripheral tissues, and one of those peripheral tissues is the brain, and it's the microglia that are really active here, or I should say it's the supporting cells. The kynurenine pathway, the kynurenine metabolism goes down two different paths in two different cells. So in astrocytes, it tends to generate kynurenic acid, which is immune modulating, immune protective, neuroprotective. It sort of reduces the immune response. And in microglia, which are the cells we see in large amounts in long COVID or in post-COVID brains, it is metabolized to quinolinic acid and NAD, which is relatively neurotoxic. How is quinolinic acid neurotoxic? Well, interestingly, it's neurotoxic by being an excitotoxin at the NMDA receptor. So the NMDA receptor is basically a calcium channel. And when it's stimulated by its normal ligand, which is glutamate, it lets in tiny amounts of calcium, which then serves as an intracellular signaling molecule. But when it's forced wide open, basically by something like quinolinic acid, calcium just floods into the cell, which activates all kinds of cell death programs, endonucleases, proteases, mitochondrial membrane toxicity, impaired cellular bioenergetics, generation of reactive oxygen species, and damage to mitochondrial and cellular DNA. So quinolinic acid does a lot of damage when it hits the NMDA receptor. Where are these NMDA receptors? By the way, they happen to be distributed a lot in the cortex, especially the dorsolateral prefrontal cortex, which is in one of the key elements in cognition; in the amygdala, which is part of key for emotional arousal; the hippocampus, which is necessary for forming new memories; and the ventral tegmental area, which is involved in limbic arousal. So kind of interesting, right, that the NMDA receptor distribution in the brain kind of maps to these areas, which are affected in long COVID. And we know that those areas, we know that there's gliosis that is generating this quinolinic acid toxin, which is going to be toxic in those particular areas. So to just sort of bring it full circle, why would an NMDA receptor antagonist be helpful in patients with long COVID? Well, this isn't the only possibility, but potentially, right? It's an antagonist at that receptor, and it would interfere with the binding of quinolinic acid, and so thus it might be neuroprotective. So, and what are the NMDA receptor antagonists? Dextromethorphan, which is very weak; amantadine and memantine, which are pretty similar; and then interestingly, ketamine, which is a strong binder, which kind of leads to the question of, gee, if amantadine is helpful, could ketamine be more helpful? And I think Mike Broad in Austin, where is he? He's in Texas somewhere. He's working on that. So anyway, so that's kind of our theory in a nutshell, is that, that if quinolinic acid levels should correlate with amantadine efficacy, that is, where quinolinic acid is high, those are the patients in whom you're likely to see, here comes my little cat, where you're likely to see amantadine being most effective. So that's our theory. I will
That
pause
is
there.
really, yeah, that is very, very fascinating. And thank you for walking us through the pathophysiology and the biochemistry of, the cognitive symptoms. I think this really, explained it so perfectly. And now it does make sense where the NMDA receptors are and why cognition might be affected. So this brings me now to the very exciting part of your work, which is, the amantadine trial. Please tell us about the study you are doing on amantadine and how did that come about?
Well, sure. Thank you. And so briefly, how it came about is there was there was a donor who was interested in supporting research on long COVID. And this donor went to university administration and fundraising and said, how can I support this work? And they initially channeled it through their basic science operation. And the idea was, well, the proposal to the donor was, well, we'll do research to understand what is, the basis of long COVID and the pathophysiology, which is very legitimate, interesting, useful work to do. But the donor said, no, what I'm talking about is I want treatment trials. And so finally, they came around to the long COVID clinic where we were trying out treatments. And, I feel, and I'm sure all of you guys agree, that we really can't go on forever with just anecdotal evidence, right? And sort of small open label trials of a few patients. We really need solid evidence. And until we have disease specific agents, we need to know which of the repurposed agents are going to work in which patients. So that's kind of the pitch we made, and the donor was very interested. And because amantadine was the thing that we were working with at that time, that's the trial we decided to mount. So we were very lucky in that sense to have a donor who was interested in funding this work. So the basic aim of the trial is to evaluate the efficacy of amantadine in improving cognitive function and reducing symptoms in patients with long COVID. Secondary aims, we are looking at the kynurenine pathway metabolites as disease biomarkers, as I kind of explained earlier. We are going to try to make a distinction between cognitive symptoms and cognitive impairment, and which, if either, is affected by amantadine. Beyond that, we do have this whole exploratory proteomic genomic analysis we're going to do, which we should be able to correlate well with phenotypes because we're collecting all kinds of data on these patients. And then acceptability of amantadine, like how tolerable is it for patients who take it. This is our simple study diagram, and I think the takeaway here is we're aiming as a pilot trial to enroll 60 patients. They'll be blinded, they and the investigators, so it'll be double blinded to treatment versus placebo. And then we're doing both patient-reported questionnaires of their symptoms, we're doing objective cognitive testing, and then the other measures that I mentioned. And we're doing this at basically 30-day intervals. So it'll be a 4-month trial. Outcomes would be improvement in cognitive symptoms. We're using the NIH PROMIS, cognitive subset. The patient assessment of own functioning, which I don't know if you're familiar with it, but it's a really detailed kind of functional questionnaire. And then the improvement in cognitive functioning using this NIH toolbox cognitive testing battery. Quinolinic acid and kynurenine metabolites. You guys are super familiar with that by now. And then those are kind of the outcomes mainly that I wanted to talk about. The other ones I mentioned briefly. So that's the trial. And we're about halfway through enrolling, and hopefully by this time next year, I'll have some actual data to report to you. So
this is very exciting, really exciting, and a study and much anticipated because we will hopefully, get some sort of impactful answers and make a difference to our patients who are struggling with brain fog. So thank you for sharing this. I wanted to now talk about other research going on at the OSU related to long COVID, and I think Hiba is going to tell us about that.
Oh, I better unshare my screen. Sorry, hang on one sec.
Okay. Thank you so much for having me. I'm Dr. Hiba Ammer. I'm in the Department of Microbiology and Immunology at OSU. And if I may, I just want to share my screen. And is my screen shown? Okay, so thank you so much for having me. It's an absolute honor being here. And before I begin talking about our current research plans, I did want to talk about the amazing $15 million PO1 grant that was granted to OSU in order to study SARS-CoV-2 mediated pathology and coagulopathy. And I wanted to give a bit of a backstory about how exactly this grant came to be. And the story starts with the caspases. Now, just to give a quick overview of what caspases are, just in case anyone isn't familiar, caspases are essentially a family of enzymes, proteases to be exact, that play very important roles when it comes to immunity. They cause cytokine maturation, inflammation, cell death. And while there are different types of caspases with different roles, I'll be focusing on the inflammatory caspases. In human beings, the inflammatory caspases include caspase 1, 4, 5, and in some human beings, 12 as well. And while there are not any caspase 4 and 5 in mice, they do have caspase 11, and caspase 4 and 5 are considered human orthologs of caspase 11 in mice due to the similarities in their structure, in their function, in their mechanism of action, and their effect on disease. And while caspases do play a very important role when it comes to immunity, their overactivation tends to be detrimental when it comes to disease outcome. Thus, our department has been very interested in studying caspase 11 as a potential therapeutic in different disease outcomes. And through research that has been published and research that is soon to be published, we've seen that caspase 11 deficient mice tended to do better in various disease outcomes and different conditions, such as bacterial infections like Staphylococcus aureus, Legionella pneumophila infections, and even in other conditions like gout and asthma. Now, when the COVID pandemic happened, this interest in caspase 11 or caspase 4 also extended to SARS-CoV-2. That is exactly what the lab sought out to do. And in 2022, we did show that there was an exacerbation disease severity of SARS-CoV-2 in the caspase 11 mice. The caspase 11 deficient mice did better. And we've also shown in human samples that caspase 4 was upregulated in the patients that tended to have worse outcome and worse pathology. And as fascinating as all this isn't where the story ends. So our interest in the role that caspase 11 plays in SARS-CoV-2 also extended to knowing how it affects the outcome of long COVID. And just to give a little bit of background about the science behind this, we know that infecting mice with the MA10 strain of the virus, MA10 stands for mouse adapted 10 strain, and if we wait about 2 weeks until the virus is cleared from the mice's system, the mice are completely over the active phase of the disease and are considered no longer contagious. This is considered a model of studying long COVID in mice. And so we also tested the mice at 30 days post-infection after infecting them with the MA10 virus. And we saw that the differences between the caspase 11 deficient mice and the control group were in fact still evident even at 30 days post-infection. And while this research has not been published yet, we're hoping we'll get it published by this year. The preliminary data did show that the mice that lacked caspase 11 were in fact protected from the outcomes of long COVID. And some of the findings we saw in the control group, the group which did not lack caspase 11, includes increased synaptic dysfunctioning, decreased hippocampal neurogenesis, increased astrocyte reactivity with increased destruction of oligodendrocytes, and decreased myelination and myelin plasticity. And This was the basis of the PO1 grant and what prompted OSU to want to investigate even more about the pathophysiology of long COVID in mice, and to also potentially test for different therapeutics that could be available. And as fascinating as all these findings were, we also realized that in order to fully be able to appreciate the pathophysiological findings that we were finding, we needed to be able to correlate that with how exactly it impacted mice's behavior. And we also needed to be able to understand how it impacted mice's cognitive abilities. And at first we considered equipment that is available at OSU, like the Y maze, like the Barnes maze, like the Morris Water maze. We realized that there were a little bit of limitations when it comes to those equipment due to only being able to test one mouse at a time, only the poor reproducibility when it comes to those kind of testing. And also because it causes a lot of undue stress on the mice, and it's limited the amount of times you can test these same mice using these mazes or equipment. So OSU invested in a very expensive but very fascinating piece of machinery called the IntelliCage. Now, the IntelliCage is a fully automated system that allows us to assess the behavior and cognitive functioning of mice in a social setting and with minimal human interference. Each cage can house up to 16 mice at a time, and we can measure simultaneously their behavior, their cognitive abilities using various tests, their memory, both short-term and long-term, their anxiety levels, their depression, and so much more. The idea behind the cage is that every mouse, before we add it to the cage, we inject it with an RFID. And using this RFID, the machine can track the mice's behavior 24/7, and as long as the mouse is essentially alive. Each cage has 4 corners, and every corner is where the mice can access water. Now, the mice have full access to food, and they have full access to the enrichment units or the housing units, the red units that are shown in this picture. However, their access to water is what is conditional. And this is the basis of a lot of the testing that we're able to perform on these mice. Now, as you can see in this picture, this is a diagram of the inside of the machine, and A shows how the mice are able to enter a corner. There's a small tunnel that they're able to move inside. And in B, you can see what the mouse sees once it's inside the corner. Now, there are 2 doors per corner, and these doors can be open or closed depending on the different limitations that we're adding or whatever test we're currently implementing. And there are lights above the door. These lights play various parts of testing. Again, it depends on what testing we're currently conducting. And once inside the corner, the mouse's presence is detected, and every movement of the mouse inside is also detected. So the mouse can perform a nose poke where it tries to in order to access the water. And it also measures every lick that a mouse does. And this is the basis behind a lot of the different types of testing that we can do. So just to give a few examples about what exactly is possible, a very, very simple test that we can do to the mice that would only last a couple of days, that would give us very valuable information, is that if we assign randomly, every corner only allows access to a specific group of mice. And then we test the mice's ability to understand that there are limitations, that 3 corners do not allow access to water, but 1 does. And in that correct corner, when it does a nose poke, this causes the door to open and allows access to water. This way, we're testing the mice's ability to learn new information. We're testing the mice's short-term memory and spatial awareness in order to be able to remember which corner allows that specific mouse access to water. And then in a few days, we can reverse the corner. So for example, if mouse A had access to the upper left corner, we can cause it to have access to the bottom right corner. And that way we're testing the mice's ability to learn new information. And again, we're assessing their short-term memory and their spatial awareness in order to see if the mouse remembers the new information in the new corner that it's been assigned to. Another quick example that I can give that it's a more complex test, but again, still gives us very valuable information, is that if we apply the same concept where every few mice are assigned to a corner randomly, and in that corner, the mouse has to do a nose poke in that correct corner, wait for 2 seconds, and then after the 2 seconds, the lights go on. And once the lights are on, if the mouse does another nose poke, the door opens and allows it access to water. That way, we're measuring if the mice are impulsive. If they nose poke before the 2-second delay, before the lights go on, we know that the mice are being impulsive. We're also able to analyze the mice's ability to follow a series of tasks in order to reach the reward. At this point, we're measuring the mice's ability to recognize the correct order, to recognize the correct actions it has to perform, and the correct environmental conditions that have to be met in order for the mice to access the water. And there are so many different ways that we can test the mice's cognitive abilities and depression symptoms and anxiety, but I'll just, if someone wants me to give more examples, I would absolutely love to, but I'll just move on right now to the current research plans that we're conducting right now. Now, our current research plans include infecting mice with the MA10 version of SARS-CoV-2 at Ohio State University's Biosafety Level 3 facility. Ohio State has a fully certified Biosafety Level 3 facility that allows us to conduct experiments using SARS-CoV-2. And then after the active stage of the infection is over, once the mice are no longer contagious and once the virus has been cleared from their bodies, we are able to remove the mice from the Biosafety Level 3 facility, and we're planning on administering amantadine to one group while the other group will act as a control. And then we're planning on placing them in the IntelliCage to assess their baseline behavior and their different cognitive functions depending on the different type of testing we're conducting. And then we're planning on analyzing the brain in various ways, including immunohistochemistry, RNA scope, Western blots to test out the different proteins or metabolites that we're expecting to see decrease or increase. And we're also planning on studying the peripheral nervous system by collaborating with Dr. Christy Townsend's laboratory. And we're planning on correlating all these pathophysiological findings with the findings that we saw in the IntelliCage. And then we're planning on repeating this using different therapeutics and using different drugs and also at different timelines, because one of the advantages of the machine is that we can essentially test the same group of mice at different intervals and see if their outcome differs at all depending on how long we wait. So we can test the same group at 2 months, 6 months, a year, up to 2 years, which is the average lifespan of a mouse. So those are our current and our future research plans. And if anyone has any questions, I'd love to answer. Thank you.
Thank you so much, Hiba, for giving us the research, background and update as well. And I wanted to, coming back to the clinical setting, Andrew, just to give for the benefit of our primary care physicians here, when patients are coming with brain fog, you talked about neuropsychiatric testing, neuropsych testing, cognitive testing. What is the role of imaging? When do we order imaging like an MRI for our patients? And what is our threshold for doing that?
I think that's a great question. And I can tell you my approach. I think of an MRI as a test to rule out other diseases. It's not diagnostic for long COVID. You're not going to see something on the MRI that proves that they have long COVID, and patients have to understand that at the time you order it. But so at this point, I kind of have a sense of what long COVID looks like in patients. So first of all, I guess a red flag for me would be if a patient just seems to be having a whole lot more cognitive difficulty than what I see even in my bad brain fog patients. I had a patient recently, who, well, I mean, not to go into too many details, but she had neuropsychiatric testing, neurocognitive testing, and tested like in the lowest 10th percentile on many, many functions. And I'm like, that is not what I see in long COVID. So she's somebody who I might think, gee, is there some other disorder going on?
Mm.
Also, I look at age, right? I mean, I think I'm much more inclined to get MRIs in my older patients who are at higher risk for neurodegenerative diseases and vascular diseases. Certainly, if I see focal deficits on the neurological exam, and this is all, in some ways, it's basic primary care stuff. Like I'm sure it's what all of you guys would do too. Um, you know, I guess those are the main things. If somebody's had a picture that looks like multiple sclerosis where they've had optic neuritis, or again, if they're having like transient focal deficits, that would be a reason to do the whole contrast MRI with of brain, cervical, thoracic.
So any alarm features, a new severe headache or the worst headache of their lives,
Good point. Yeah.
any cranial nerve deficits which are new or progressive weakness, spasticity, which is new. All these alarm symptoms would trigger an MRI. Now, patients who come, sharing my own experience, patients who come to my clinic who are referred to the long COVID clinic have already had some sort of basic workup. A lot of times they have seen neurology already, but just walking the primary care physicians through this process, patients who have this cluster of brain fog symptoms, things that are helpful are vitamin B12 levels, TSH thyroid levels for sure, and basic workup, CBC, CMP, rule out depression, which most times they do have, because by now they are very worried about these symptoms. They are feeling anxious, they are feeling depressed. So overlapping depression, uh, sort of diagnosis is helpful. The other um, thing to look at is what neurosuppressive medications they are on. Are they taking a lot of benzodiazepines? Are they on opioids? All of those can compound and aggravate their symptoms. Additionally, sleep is a plays a big role in aggravating, neurocognitive symptoms. And um, lack of sleep, either falling asleep or staying asleep, or undiagnosed sleep apnea, they are very prevalent in our long COVID population. So I think, we need to address that as well. Going to the management, I think that addressing the sleep, making sure that there is no polypharmacy, looking at medications that might be suppressing the nervous system and whether they can be removed safely. Uh, the other big thing in this case is some of these patients have undiagnosed ADHD, which may be compounding their lack of focus, lack of attention, and that also probably needs to be addressed. A lot of times, Andrew, we are advising vitamin B12, some of the supplements that may work, CoQ10. What is your approach with regards to these supplements?
So I always caveat that, although I try my best, I can't read all the literature that comes out. So there may be some evidence there in favor of particular supplements, that's solid evidence that I just am not aware of. I measure the levels. I guess I supplement if they're deficient, but otherwise, I haven't really experimented with giving people super physiologic doses of B12 or B6 or B1.
And then the other thing that I really wanted to address for benefit of our of our primary care physicians here is there a role of low dose naltrexone in brain fog? Because it has shown some benefit in chronic fatigue and especially patients with polyarthralgias. Is there a role in brain fog patients?
Maybe, right? And that's another one where it seems like such low-hanging fruit to do a study of low-dose naltrexone. And has it come out? Did I just miss it? Like I have not
No,
seen
it hasn't.
anything.
No.
There was one really good study that somebody did, but they like mixed it with some proprietary supplement because it just bothers me that everybody who does a study, they have to figure out how can we like monetize this. So like, anyway, I mean, anecdotally, I find it's low risk, right? So I mean, that's one of my criteria. If I'm going to experiment on my patients, at least I want it to be a relatively harmless experiment. Um, but I do offer it, and I mean, I guess for all purpose kind of COVID, like fatigue, it seems to help with fatigue anecdotally. It maybe helps them with, this dyspnea on exertion and, exercise intolerance and post-exertional malaise. Maybe it helps with brain fog. So I do use it. There's a neat trick for, because you have to send patients to a compounding pharmacy, but there's a
Yes.
neat trick for make your own low-dose naltrexone I can share if you want.
Sure, please.
So, all right, so it comes as a 50 milligram tablet, which it happens dissolves really well in water. So if you take a mason jar and take some distilled water and put 50 cc's of water in that mason jar and dissolve a 50 milligram naltrexone in it, you now have a 1 milligram per cc solution, which the patient can then aliquot out using like an insulin syringe, and they can take their 1 milligram, 2 milligrams. It's good for 2 weeks in the fridge. I checked with all our pharmacy staff, and they say it's perfectly stable. So it's a lot cheaper than having to pay $100 a month to a compounding pharmacy. And as far as we know, it works just as well. So if you want to give them LDN, then the cost does not have to be a barrier.
Thank you for sharing this. I think this will be very helpful to our primary care docs. And I also want to share that folks at Stanford are, you know, they are doing trials on a combination of LDN and Abilify, low dose Abilify, especially in patients who have chronic fatigue, PEM, post-exertional malaise, and brain fog. So that is something to look out for. And the investigators, the principal investigators say that they have seen benefit of this combination. So I think that is something to to watch for. And as we have more evidence, that may be something to offer to our patients if it is successful. The other treatment modalities, I just want to briefly touch upon what you said earlier, is the role of speech therapists who also do cognitive rehab. So we often will send patients to them, and they have a few weeks program where they offer cognitive rehab and speech rehab. In addition, one of the anchors of treatment is pacing, because brain fog and chronic fatigue will go hand in hand. And pacing will help them with both taking breaks at work, avoiding overstimulation in terms of lights and sounds, is also helpful. Also avoiding exposure to strong perfumes is another sensory stimulus that we talk to patients about. So those are some of the practical sort of considerations and suggestions that we can give patients. Before we wind up, Andrew, I wanted to briefly touch upon some of your other wonderful work on small fiber neuropathy. Would you like to say a few words about that before we end?
Sure, if you'd like. Yes, thank you for asking, and I hope people aren't tired of hearing my voice. But Anita, I just want to say that really I agree with everything you said. That's great practical advice, and I think that outlines the approach we take with our patients too. And low-dose naltrexone, like maybe we can run that through the mouse model. Maybe Heba will have an answer for us sometime soon. But okay, let me share my screen at one more time here. Okay, share. And let's see, okay. All right, I've got a page down here. All right, so just a quick thought, sort of a teaser on the peripheral nervous system. You know, do you guys see, like, Anita, you must often see patients with dysautonomia, right? It's like, it's really a common recognized long COVID phenotype.
Yes.
Yeah, yeah. And so, if you look at kind of, this is the original CDC list of like every symptom known to man that could be caused by long COVID. And if you look at the symptoms of dysautonomia, it correlates pretty well. Like a lot of the symptoms that we think of, all right, we think if the patient's having respiratory problems, there must be something wrong with the lungs. And so you test the lungs, you do CAT scans and pulmonary function tests, and everything looks good. I mean, if the patient's having chest pain and palpitations, you do a Holter monitor and you do an echo, and all of that looks good. So you think maybe it's all in their heads. The end organs look good. But like what we're, I think, forgetting when we do those end organ tests is that all these things are controlled by the autonomic nervous system, right? And so, I mean, like, uh, you know, pulmonary symptoms like shortness of breath and easily winded, that can be dysautonomia. I think we're all familiar with kind of that POTS phenotype where people can get orthostatic, dizziness and rapid heart rate and near syncope and stuff without having anything wrong with the heart itself. It's the innervation of the heart and the regulation of the heart and the vascular system that's a problem. And on to, gastrointestinal symptoms like diarrhea or gastroparesis, these, sweats that you'll sometimes see in patients, like they'll just have these diaphoretic episodes for no reason. All of that is consistent with dysautonomia. And so an interesting kind of observation. Anita, you're familiar with stellate ganglion block? Have you referred patients for that?
Yes, I actually have not heard, I've not referred patients, but I have heard of this. But it has not been something that we have really explored in our long COVID clinic.
When it started with like a two papers which contained three cases of long COVID patients treated with stellate ganglion block. In case people listening don't know what it is, the stellate ganglia are these two sympathetic nerve ganglia that are kind of in the side or the back of the neck. And the diagram on the left shows exactly where you have to put a needle using an anterior approach to get to the stellate ganglion. And this has been used for a long time for things like PTSD and interestingly, sometimes for autonomic symptoms. But when it turns out when you block the stellate ganglion, number one, a lot of these patients get back their sense of smell and taste. How long does it last is another question. Sometimes they get 2 weeks of benefit and then go back to where they were. But when they finally got around to doing a larger case series, this was 41, not only did the smell and taste improve with stellate ganglion block, but like fatigue and brain fog and mood and dyspnea and sleep and the cardiac symptoms all improved in those patients. Small sample, again, not blinded or anything, but it's interesting that manipulating the autonomic nervous system leads to improvement in all of these symptoms. So, okay, again, just a little basic science reminder, but what is the motor system runs, your motor impulses run down these large myelinated nerve fibers, but the autonomic and sensory systems run on these sort of thin, either thinly myelinated or unmyelinated type C and fibers. And those are the parts of your nervous system that control your internal functions and pain perception, heat perception. So I really like this. This was published before COVID, but it's a nice just sort of, overview of small fiber neuropathy and how the sensory system and the autonomic systems overlap. You can ignore the sodium channel dysfunction branch there. But if you look at small fiber mediated painful neuropathy, like painful paresthesias, burning, tingling, stabbing, numbness, generalized pain, we see that in some of our patients. It's like this fibromyalgia type thing. Small fiber mediated widespread pain, which really is basically corresponds to fibromyalgia. And then also, in those patients, you often see fatigue and cognitive and sleep disturbances. And then small fiber mediated autonomic dysfunction, where you see all the things we were just talking about, like the GI symptoms and cardiac and respiratory and sweating and things like that, also overlapping with these other small fiber things. So what I'm getting at here is that, a lot of things point to like a lot of the symptoms of long COVID really could be explained by a small fiber neuropathy. I don't have the slides, but it like relatively few studies have been done. It's surprising how little work has been done. there were maybe 2 or 3 studies, all of which showed a fairly high prevalence when they looked at skin biopsies of small fiber neuropathy in their symptomatic long COVID patients. And then the other just interesting teaser here is, okay, it sort of makes sense that you would have painful paresthesias and autonomic symptoms, but what about the brain symptoms? We've been super hyper focused on the brain as where, these brain fog must come from. There must be primary pathology in the brain, even though there's relatively little evidence for viral invasion of the brain, and the blood-brain barrier protects against even a lot of immune mediators and immune cells. It's relatively limited what can get through there. But we sort of forget that, like, the brain doesn't work without input from the peripheral nervous system. The whole purpose of the hippocampus, and the reason it sits where it does, is to kind of be at the intersection of sensory information and internal information from the autonomic nervous system that then tells the organism like what it needs to do to maintain homeostasis. And that's why we have a hippocampus and why we generate memories, is so that we can learn from our previous experiences where what meets our homeostatic needs, right? And so one of the mediators of this is this central brain-derived neurotrophic factor, which is absolutely essential for adult hippocampal neurogenesis, right, which is a prerequisite for memory formation, learning ability, mood regulation, and stress response. And that is very much influenced by afferent fibers from the vagal nerve, right? So the peripheral nervous system is talking to the central nervous system. And if the peripheral nervous system is whack, then the hippocampus is whack, right? So there's just an interesting theory here, and I think it really is worth looking at the peripheral nervous system as possibly the primary location of the lesion in long COVID. So that, and we have a grant proposal in. I'll just leave it there. Maybe if we're funded, maybe we'll be able to talk more about that.
Thank you so very much, Andrew. This was very insightful. Thank you for, I love that you walked us through the pathophysiology and, again, the basics, which really makes things very, very clear. We have one question from the audience. I think it's Rancherji. Rancher, you can unmute yourself and please ask the question.
Hello. Hi, can you hear me?
Yes.
So, hi, Doctor. Thank you so much for the information. So I have a quick question. So what dose of amantadine do you prescribe to the patients? And is this something that they have to take ongoing?
So, that's a great question. Thank you. The standard starting dose for me is 100 milligrams twice a day. Twice a day, they have to remember to take first dose in the morning, second dose in the early afternoon, like maybe between noon and 2 p.m., because if they take it too late, it will keep them awake because it is a stimulant. You can go up as high as 400 milligrams a day. If you have a patient who says it's helping but not enough, try 300 and try 400. And yeah, it's really meant to be taken daily. I haven't really tried like the PRN amantadine. Like, could you just take it, before like a test or something like that? That's not how I prescribe it. That's not really how I would recommend it. So yeah, take it as. However, as far as like how soon will they know if it works, my experience has been within a week or two, patients know. Like they'll either say, "Wow, I feel a difference," or they don't. And if you've gone on a month and the patient hasn't seen a difference, just stop it. It's probably not gonna help.
Thank you for that. And this brings us to the end of the town hall today. Thank you so very much, Andrew and Hiba, for sharing this valuable information. And this was a very, very informative session. Thank you for being with us today.
Thank you, Anita. And thanks to all the audience for.
Thank you so much, Dr. Smith.
We really appreciated having you.
Thank you.
All right.
Bye.
Take care now.